Hello, I am Dr. K. Paul Stoller, a fellow of the American College of Hyperbaric Medicine. Polytrauma syndrome remains one of the most challenging conditions in modern medicine, particularly among military veterans and individuals with traumatic brain injury. Despite decades of research, many patients continue to suffer from persistent symptoms: depression, anxiety, cognitive impairment, fatigue, and tragically elevated suicide risk. This video explains a proposed integrative clinical protocol that approaches polytrauma not as a single injury, but as a systems-level disorder involving the brain, metabolism, and the neuroendocrine system. So, polytrauma syndrome commonly involves both traumatic brain injury and post-traumatic stress disorder. But growing evidence shows that the damage does not stop at brain structure or psychology. Many patients develop neurometabolic and neuroendocrine dysfunction, particularly involving the hypothalamic pituitary axis. Studies show that 20 to 50% of TBI patients develop some form of pituitary dysfunction. These abnormalities can quietly drive many of the symptoms we struggle to treat. Following TBI, the hypothalamus and pituitary gland may no longer function normally. TBI victims are often deficient in testosterone and luteinizing growth hormone oxytocin, as well as having dysregulated vitamin D metabolism. The consequences of low testosterone and oxytocin are depressed mood, reduced motivation, cognitive impairment, lower quality of life, fear responses, emotional dysregulation, and social withdrawal. These are not secondary issues. They are central drivers of suffering in polytrauma. This protocol begins with comprehensive metabolic and hormonal assessment, including total and free testosterone, dihydrotestosterone, or DHT, estradiol, luteinizing hormone, growth hormone, vitamin D levels, hemoglobin, A1C, and standard metabolic and inflammatory markers. Post-TBI hypopituitarism remains underdiagnosed despite strong evidence of its clinical relevance. Intranasal oxytocin, or sublingual oxytocin, has been shown to reduce anxiety, modulate amygdala activity, and support trauma processing. It is proposed as an adjunctive therapy, excluding pregnancy and active opioid dependence. Oxytocin helps regulate the limbic system, often hyperactive after trauma. For secondary hypogonadism, the protocol proposes Enclomiphene, a selective estrogen receptor modulator. Enclomiphene stimulates endogenous testosterone production, preserves spermatogenesis, avoids testicular suppression seen with direct testosterone replacement. Careful monitoring is essential. DHT levels to manage prostate risk, estradiol levels to avoid estrogen excess, and when indicated, aromatase inhibitors such as anastrozole may be used. For patients with insulin resistance or elevated A1C, berberine is proposed. Berberine activates AMPK, inhibits mTOR signaling, and demonstrates glucose-lowering effects comparable to metformin. Meta-analyses suggest similar efficacy with improved tolerability in some patients. Now, last but not least is treating the brain injury itself. Hyperbaric oxygen therapy. The cornerstone of this protocol is low-pressure hyperbaric oxygen therapy. Hyperbaric oxygen has been shown to enhance cerebral metabolism, improve mitochondrial function, promote angiogenesis, and support neuroplasticity. This protocol utilizes 1.5 ATA, 60 minutes per session, once daily 2 cycles of 40 sessions. Low-pressure protocols have demonstrated improvements in cerebral blood flow, cognitive performance, and post-concussive symptoms. It is imperative to screen for neuroinfectious contributors before initiating hyperbaric oxygen. Screening for neurospirochetal infections, such as Borrelia, may be considered. These organisms can involve the central nervous system and may react adversely to hyperoxic environments. Screening improves safety and reduces inflammatory complications. Following metabolic stabilization and HBOT, some patients may benefit from modafinil, improves attention and executive function, enhances wakefulness, lacks the addictive profile of amphetamines. It may help the cortex sustain increased metabolic activity following neuroplastic recovery. Why this all matters? A question that should not even be necessary to ask with 20 veteran suicides every day. Polytrauma syndrome is not a single pathology disorder. It is a multi-system condition involving brain injury, hormonal dysregulation, and metabolic dysfunction. Neuroenergetic failure. Conventional care often treats symptoms in isolation. This protocol proposes a systems biology approach, integrating domains that are usually siloed. Given the ongoing burden of disability, suffering, and suicide associated with polytrauma, the use of integrative approaches is not only reasonable, it is ethically necessary. What does that mean? It means given there are 20 to 30 suicides a day from veterans, you don't wait for even one more study, you start treating now. Treat now!